Hello students, I welcome you all to Obstetrics and Gynecology with Mackler. So in this module, we're going to discuss about the treatment of abnormal uterine bleeding. So in the previous module, we dealt about the endometrial biopsy where the report came out to be endometrial hyperplasia with atypia and without atypia. So the treatment of endometrial hyperplasia with atypia and without atypia and the approach and the treatment will be discussed in the subsequent module. So before discussing about the reports of endometrial biopsy, I thought it would be better if I teach you the treatment of abnormal uterine bleeding so that subsequently it will be better for you to understand the approach and treatment of endometrial hyperplasia with atypia and without atypia. So in this module, our whole approach is going to be towards the treatment of abnormal uterine bleeding. Okay, so going with the treatment of abnormal uterine bleeding, we are going to discuss this in three subcategories. So the three subcategories, that is the three sets of treatments which are available, are the non-hormonal, the hormonal, and the procedures which can be done in a patient with complaints of heavy menstrual bleeding. So what are the non-hormonal approaches? So the non-hormonal approaches are the tranexamic acid, right? So tranexamic acid is the non-hormonal treatment which has to be done in a female with complaints of heavy menstrual bleeding. So tranexamic acid belongs to a group of drugs called as antifibrinolytics. So basically fibrinolytic means breakage of fibrin. So once there is going to be breakage of fibrin, there is going to be breakage of the blood clots. But antifibrinolytic means it is going to improve the blood clotting. So you're basically going to improve the blood clotting in that female who is having the complaint of heavy menstrual bleeding. So once the blood is going to get clotted, then therefore she will be prevented from heavy menstrual bleeding. So in order to prevent heavy bleeding in her, you're going to give this tranexamic acid. So this tranexamic acid is going to improve the blood clotting and prevent the heavy menstrual bleeding in that patient. Right? Okay. So this tranexamic acid can be administered to any patient with complaints of heavy menstrual bleeding. In order to stop the bleeding, you're going to administer this tranexamic acid. So this is a non-hormonal approach. So now we are getting inside the hormonal approach. So before discussing about the hormonal approach, let me discuss about what are the hormones which we are going to take into consideration in the treatment of heavy menstrual bleeding. So the first hormone is estrogen. So as we all know, estrogen, the main function of estrogen in the uterine endometrium is to proliferate the uterine endometrium. So since there is going to be proliferation of the uterine endometrium, there is going to be proliferation of the uterine glands, right? So this is going to result in heavy menstrual bleeding, because whenever the endometrium is going to get proliferated due to the lack of support by the progesterone, it is going to result in breakthrough bleeding, that is heavy menstrual bleeding. So this is all about the estrogen. And progesterone is a hormone which supports the endometrium. So as I have discussed in the previous module, let's take this is the endometrium. And this red color structure is the estrogen. So the main function of estrogen is to proliferate the uterine endometrium. And the blue color structure which you are seeing here, this is the progesterone. So the main function of progesterone is to support the uterine endometrium which was primed by the estrogen, right? So once the uterine endometrium is primed by the estrogen, then progesterone will come into play, and the major function of progesterone is to support the uterine endometrium, right? So in other words, it can be called, it is having some anti-proliferative effect. Estrogen has proliferative effect on the uterine endometrium and progesterone has anti-proliferative effect on the uterine endometrium. So once the progesterone is going to come into play and support the endometrium, it is going to prevent heavy menstrual bleeding, because if the progesterone is going to bind the uterine endometrium, then definitely no bleeding will happen, right? So only if there is going to be withdrawal of the progesterone, then the uterine endometrium will lose its supports and it will result in bleeding. But unless and until progesterone is going to support the uterine endometrium, there is going to be no bleeding per vagina. So this will prevent heavy menstrual bleeding. So please remember, estrogen alone causes proliferation of the uterine endometrium. Progesterone alone causes anti-proliferative effect of the uterine endometrium, such that if you give only progesterone to a female, it will result in thinning or atrophic endometrium. The endometrial thickness will get very thinned out and it will be atrophied, right? Okay. And the most important note here is that progesterone will only act on a uterus which was primed by the estrogen. unless and until estrogen is not priming the uterus, then progesterone will never come into play. Clear? Yes. So now we are getting inside the hormonal approaches. So the first hormonal approach is the oral contraceptive pills, which are most popularly known as the OCPs. Clear? The oral contraceptive pills. And now I'm going to make this session very interesting. In such, we are going to discuss this as case. So the case one is that, let's say a female, she came to me with complaints of heavy menstrual bleeding. A reproductive age group female, she came to me with complaints of heavy menstrual bleeding per vagina. Now, as I told you, in all reproductive and perimenopausal age group female, the first investigation is to send her for urine pregnancy test in order to suspect any pregnancy. So she has done her UPT and the UPT came out to be negative. So since the UPT is negative, now I have to send her for ultrasound, that is transvaginal sonography. In transvaginal sonography, the endometrial thickness is very thick. So the ET is thickened endometrial thickness, right? So endometrium is thickened on ultrasound. So since the endometrium is thickened, which comes out to be as a report in ultrasound, it means that estrogen has played its part in its uterus, right? Only if estrogen has played its part in the uterus, then the endometrial thickness will get thickened, right? So here the endometrial thickness is very thickened. So this means that estrogen has primed the uterus. So since the estrogen has primed the uterus, the patient is having heavy menstrual bleeding, because once the uterus is going to be primed by the estrogen, it is going to result in breakthrough bleeding, because the support by the progesterone is lacking in that uterus, because the levels of estrogen are very high in that female. There is going to be proliferation of the uterine endometrium, and since it lacks the support by the progesterone, it is going to result in breakthrough bleeding. So since the endometrial thickness is going to be very thickened, it results in heavy menstrual bleeding. So here, since estrogen has already primed the uterus, the treatment which I have to instill here is only the progesterone. So you give only the progesterone containing pills. Because the estrogen has already primed the uterus, now my function is to do, how am I going to treat this patient? Since the uterus is already primed by the estrogen, now I have to give only the progesterone, so that this progesterone will go and support the uterine endometrium. And unless and until this progesterone is going to support the uterine endometrium, the patient will never have any bleeding. So if you are going to give progesterone containing pills, you can give either in a continuous fashion, you ask the female to take continuously, or you give it in a cyclical fashion, ask the female to take only for 12 to 14 days and then ask her to repeat in the next cycle. So either you ask the female to do it in a cyclical manner or take it in a continuous manner. So both of this is going to prevent the heavy menstrual bleeding, right? If you're going to give in a cyclical manner, it is going to result in regularization of the menstrual cycle, and the bleeding will also get subtle. If you're going to give in the continuous manner, since there is going to be no withdrawal of the progesterone, the patient will never bleed at all. But if you give in a cyclical manner, you give it for 12 to 14 days and then you stop the progesterone, the patient will have bleeding, and then ask her to start the progesterone for the next cycle for 12 to 14 days and ask her to stop again. She will have bleeding, and in this way the cycle, the menstrual cycle in that female will get regularized and the bleeding will also get controlled. If in case you're going to give it in a continuous manner, and unless and until the patient is going to take her pills without missing any pills, she is going to take her pills regularly, the patient will never have any bleeding unless she stops her pills for at least 3 to 4 days or more. Clear? Yes. So this is all about the case 1. So case 1 where the thickness of the endometrium was increased. So there was increased endometrial thickness. So the estrogen was already primed. Now my function is to produce only the progesterone. So I gave only progesterone to this female. Good. Now we are going to the case 2. So in case 2, similarly, a reproductive age group female came to me with complaints of heavy menstrual bleeding. So now, since she is a reproductive age group female, I sent her to urine pregnancy test. So the urine pregnancy test came out to be negative. So now I have to send her for his ultrasound, that is the transvaginal sonography. So in transvaginal sonography, the report came to me as the endometrial thickness is very decreased, that is the endometrium is very thin. So since the endometrium is very thin, it tells me that the estrogen has not played its part in the endometrium. If estrogen is going to play its part in the endometrium, then definitely the ET thickness is going to be increased. But in this case, the endometrium is very thin. So since the endometrium is very thin, it tells me that estrogen is not coming into its play. So in such patients, the treatment is going to be estrogen followed by progesterone. Why? Because progesterone cannot act in a uterine endometrium unless it is primed by the estrogen. So first you give the estrogen followed by the progesterone. So you can either give it by oral combined pills, you give both the estrogen plus progesterone, or you can give IV estrogen first followed by the oral progesterone. So you give the estrogen, proliferative action, and then you give progesterone. It supports the uterine endometrium and this will prevent the female from heavy menstrual bleeding. So is that clear? Yes. So this is all about the hormonal management. The first management was oral contraceptive pills, OCPs. So this can be given either only progesterone or both combination of estrogen plus progesterone. Clear? Yes. So now we are going to deal with the third. The third part is the hormonal. So hormonal, first we have discussed about the progesterone only pills. Second was estrogen plus progesterone pills. And the third one is going to be intrauterine contraceptive device. Right? So this is the third one is going to be intrauterine contraceptive device, which is going to contain progesterone. So progesterone containing intrauterine contraceptive device. So what do you mean by intrauterine contraceptive device? So a device is going to be placed inside the uterus. So as you can see in this image, this is the intrauterine contraceptive device, which is called as Mirena, and this is going to contain progesterone. And what is the progesterone which is contained in the Mirena? It is called as levonorgestrel. Levonorgestrel containing IUCD, that is the Mirena. So as you can see here, this is the levonorgestrel containing Mirena. So it is placed inside the uterus. So what is the function of this IUCD is that it is going to release progesterone in a sustained manner. That is, it is going to release at least 20 microgram of progesterone per day. So you don't need to ask the patient to take any pills. You take pills for 12 days, 14 days and then stop, or you ask the patient to take the pills on a continuous basis. You need not ask the patient to do anything. You just put this IUCD inside her uterus and this IUCD will stay in place, and this IUCD is going to be effective for the next 5 years. It is going to be effective, and every day it is going to release about 20 microgram of progesterone per day. And how much is the levonorgestrel the IUCD is containing? It is about 52 milligram. 52 milligram of progesterone is containing. The progesterone is levonorgestrel. So if there is an MCQ, how much amount of progesterone, that is levonorgestrel, is present in Mirena? It is 52 milligram. But how much progesterone is released by the Mirena per day? It is about 20 microgram of progesterone is released per day. Right? So the entire amount is 52 milligram and it is releasing about 20 microgram of progesterone per day. Right? Yes. And the lifespan is about 5 years. So for 5 years, you need not worry about this IUCD. Unless and until it is going to be misplaced, it is going to cause no other problem. Initially, once you are going to insert this IUCD inside her uterus, there might be certain discomfort. The patient might be experiencing some sort of bleeding or some discomfort, but then eventually she will be overcoming all those symptoms, and this is going to be the effective also. So the ideal lifespan of this IUCD Mirena is 5 years, but then it releases the levonorgestrel for about 7 years. So what generation of IUCD is Mirena? So this belongs to third generation IUCD. So once I am going to take you the class of contraception, I will be discussing about everything. In that we will be discussing about IUCD in detail. But as of now, the treatment of abnormal uterine bleeding, one of the hormonal treatment is IUCD containing Mirena. Right? Okay. And this IUCD containing Mirena is also called as LNG20. What is LNG20? Levonorgestrel, and this 20 is because it is going to release 20 microgram of progesterone per day. So it is LNG20. Clear? Yes. So this is all about the hormonal management. So the first one we discussed was non-hormonal, that was tranexamic acid. The second one was hormonal, in which we discussed progesterone only pills. estrogen plus progesterone pills, and the third one was the IUCD Mirena, intrauterine contraceptive device Mirena. Clear? Yes. The third approach is going to be the procedural approach. So what are the procedures you're going to do in a patient with complaints of abnormal uterine bleeding? So the procedures which I'm going to do are 3 procedures, right? So the first procedure is dilatation and curettage. So this dilatation and curettage is basically done with the help of what? You're going to dilate the cervix and you're going to insert the curette, that is an instrument where you're going to insert it inside the uterine endometrium, and you're going to just curette whatever tissue is going to be present. You're going to curette the entire uterine endometrium, that is the entire uterine cavity. We know it is lined by the endometrium, right? With the help of this curette, you're going to curette out the uterine endometrium. So once you're going to curette and remove the uterine endometrium, then the endometrial thickness will get decreased, and therefore the patient will be relieved from the symptoms of heavy menstrual bleeding, right? Is that clear? Let me show you here. Let's say, for example, this is going to be the uterine endometrium, right? This is going to be the uterine endometrium. Now I'm going to introduce a curette. This curette has a rough surface. So with the help of this curette, I'm going to curette out the entire uterine endometrium. You just curette it out. So once you're going to curette or scrap the endometrial tissue which has been present in the uterine cavity, everything will be removed off, and then you send it for histopathological examination. And once you are going to remove the uterine endometrium, the endometrial thickness is going to get decreased, and therefore the patient will be prevented from the symptom of heavy menstrual bleeding. So this is the dilatation and curettage. Dilatation means you're going to dilate the cervix. Once you dilate the cervix only, you can introduce this curette inside the uterine cavity. So it is dilatation followed by curettage with the help of the instrument curette. Right? Okay. So once we are going to discuss about the instrument section in gynecology, I will tell you about the uterine curette. Right? Okay. So the first approach was the dilatation and curettage. The second approach is endometrial ablation. Endometrial ablation. So ablation means destruction. So ablation means destruction, where basically you're going to cause destruction of the uterine endometrium. And the destruction of the uterine endometrium can be done by 2 methods. The first method is the resectable method, and the second method is the non-resectable method. So first, let's deal about the resectable method. So this resectable method of endometrial ablation is the first generation method. And this first generation method is done with the hysteroscopic guidance. What is hysteroscopy? As you can see here, this instrument is the hysteroscope. Hysteroscope is similar to your endoscope, where it is going to be a camera held device which you're going to introduce per vaginum inside the female's uterine cavity, so that you will be observing whatever the inside approach. Let's say, for example, in order to detect any focal lesions in the uterine cavity, with the help of this camera held hysteroscope, you're going to visualize it in the exterior. So with the help of a monitor, you're going to visualize everything. So under hysteroscopic guidance, this endometrial ablation can be done. So the first, that is the resectable method, which is the first generation method, which is done with the hysteroscopic guidance. The methods are transcervical resection of the endometrium. Through the cervix, you're going to introduce, through the hysteroscope, you're going to visualize, and through the cervix, you're going to introduce the instrument, and you're going to cause resection of the endometrium. You resect the uterine endometrium. So some similar procedures are the wire loop, the roller bar, and the laser. So all these are the different methods of resectable method. So you just need to learn about the terms, because no questions are asked about these, but you need to know about these words. So what are the resectable method? Transcervical resection of the endometrium, wire loop, roller ball, and laser. So these are the resectable method. So with the help of the resectable method, you're going to cause destruction of the uterine endometrium, and destruction can be to a depth of about 4 to 6 millimeter. So up to a depth of 4 to 6 millimeter in the uterine endometrium, you're going to cause the destruction of the uterine endometrium. So resectable methods are transcervical resection of the uterine endometrium, wire loop, roller ball, and the laser. So whether there is a risk of fluid overload with the resectable method? Yes. Why yes? Is because this is done with hysteroscopic guidance. So whenever you're going to do hysteroscopy, definitely there will be risk of fluid overload. So since it is done under hysteroscopic guidance, the fluid overload risk is present. Clear? Yes. So now we are moving to the non-resectable method. So non-resectable method, sorry, there is a spelling mistake here. Let me correct it. Non-resectable method. So this is the second generation method. Resectable method is the first generation method. Non-resectable method is the second generation method. So the second generation method can be done without the hysteroscopic guidance. You're not going to use any hysteroscope. Since you're not going to use any hysteroscope, therefore the risk of fluid overload is not present. So no risk of fluid overload. So what are the examples? Hydrothermal ablation and cryosurgery. So basically with the help of current and with the help of freezing procedure, you're going to cause destruction of the uterine endometrium. That is the hydrothermal ablation and cryosurgery. With the help of freezing process, you're going to cause destruction of the uterine endometrium up to a depth of about 4 to 6 millimeter. Since it is not done under any hysteroscopic guidance, therefore the risk of fluid overload is not present. So what are the indications for uterine endometrial ablation? So endometrial ablation is where you're going to cause destruction of the uterine endometrium. So once you're going to cause destruction of the uterine endometrium, then definitely the patient cannot get pregnant, right? So for that reason, the indication is only in patients who have completed their family. Right, because endometrial ablation is a procedure where you're going to cause destruction of the uterine endometrium. Once you're going to destruct the uterine endometrium, then it is very difficult for the patient to get pregnancy because the implantation won't happen properly in the uterine endometrium because the endometrium is destructed. So in patients who have completed their childbearing, the family is complete, in those patients you can adopt this endometrial ablation. Let's say for example around 40-year female, 45-year-old female, even 35-year female who have completed their family. And what are the contraindications? So the contraindications are, the most important contraindication is pregnancy. If a female is going to be pregnant, in a pregnant female, are you going to do endometrial ablation? No, never. You can't do this, right? So in pregnant females, you cannot do this procedure. And any female with intrauterine contraceptive device in situ, you can't do because the device is kept inside the uterus. So with the device in situ, you can't perform this destruction of the uterine endometrium. Apart from that, if you're going to suspect any kind of endometrial hyperplasia, which is the hyperproliferation of the uterine endometrium, where there is going to be proliferation of the uterine glands, which is called as hyperplasia of the uterine endometrium. There could be any chance of atypical nuclear features being present. So in that case, or where there is endometrial hyperplasia, you cannot do this procedure. And in patients with endometrial cancers, you cannot do this procedure. Apart from that, any sort of infections, any acute infections, such as example any pelvic infections, because the infections can actually get aggravated or it can even spread. So in order to prevent any sort of infectious spread, you cannot do this procedure of endometrial ablation in any patient with acute pelvic infections. So please always remember, any sort of infections in a female in gynecology, you cannot do any procedure. So in acute pelvic infections, you cannot do. And in case of pregnant females, IUCD in situ, suspecting endometrial cancer or hyperplasia, in those females also, you cannot do this procedures. Right? So these are the contraindications of endometrial ablation. Right? Yes. So as you can see here, what is this procedure? This is the endometrial ablation, where you're going to cause destruction of the uterine endometrium up to 4 to 6 millimeter. Up to 4 to 6 millimeter, right? Yes. And the third procedure, the last procedure, is hysterectomy. What is hysterectomy? Removal of the uterus, right? In such cases, you can do removal of the uterus also. So far we have discussed about the non-hormonal approach, which is the tranexamic acid, the hormonal approach, which was the progesterone-only pills, estrogen plus progesterone combined pills, and then we were discussing about the IUCD Mirena, and the third approach was procedural aspects, where we discussed about the endometrial ablation, the resectable and the non-resectable methods, dilatation and curettage, and the third method was hysterectomy. So when will hysterectomy be considered in a female is that irrespective of doing all the treatment, the patient is not effective from the treatment, she continues to bleed. In such cases, in elderly patients who have completed their childbearing and they are nearly 45 to 50 years, in that female you can consider hysterectomy, because anyway after 50 years, she's around 47 to 51 years, she's going to attain menopause. So after menopause, there is going to be decline in the levels of estrogen, so it is equal to with the uterus and without the uterus in a female. So in elderly patients who have completed the menstrual cycle around 45 to 50 years, you can consider hysterectomy options, but definitely less than that, you need to go with the other options such as the endometrial ablation, dilatation and curettage and such. If she is an elderly female, then you can go with the option of hysterectomy, right? So this was all about the treatment of abnormal uterine bleeding. I hope that I made this session is very interesting for you, right? So I hope you understood everything, and if a question is asked to you about the treatment of abnormal uterine bleeding, whatever I have taught you until now, this will be enough for you to score good marks in your examination. As well as if questions are asked in the MCQ based examinations, most of the questions will be asked from these aspects, right? Thank you. Please keep studying until let's meet in another interesting module. If you have any doubts, please write to us in the Mackler handle. We will reach out to you as early as being possible. And please subscribe to this Mackler Instagram and YouTube handle for daily video updates. Thank you.